Welcome to the India's second Metabolic Health Conference. I am Dr. Jasmeet, a metabolic health coach and a proud member of D-Life. D-Life, which is India's only award-winning low-carb platform. And I'm honored to be the part of this conference, which has been organized by my esteemed mentors, Shashikant Iyengar and Anup Singh, just to bring or to provide you people a scientific feast on the metabolic therapies. And today I have with me Dr. Alex Petrushevski. Dr. Alex, he's a practicing low carb doctor in Sydney, Australia, and along with his wife, Dr. Deepa Mahananda, he runs Sydney Low Carb Specialists, which is a multidisciplinary metabolic health clinic, and where they have a team of doctors, dietitians, health coaches, and even exercise physiologists. So Alex is also a foundation member of the Society of Metabolic Health Practitioners, and is also one of the directors of the Australian Metabolic Health Society, which is a non-profit organization founded in 2023 that is to help or to teach the health practitioners about the metabolic therapies. Alex is so passionate about the preventative health that he incorporates improving the lifestyle changes in the patients to improve their chronic diseases, even without the medications, if possible. So prior to his work in the low-carb space, he worked as an oncology training for several years and maintains an active interest in the cancer. So welcome again, Dr. Alex, to the India's first platform for the Metabolic Health Conference.
Thanks for having me again, Jasmeet. Good to be here.
Yeah, Dr. Alex, you were there in the earlier conference as well. So this is the second one. So welcome.
Thank you for having me.
So, Dr. Alex, I have seen you people, Dr. Deepa and you cover a wide range of metabolic health issues and you use the metabolic therapies for their treatment. Can you please talk about how your clinical practice has evolved over time?
Yeah, sure. So as you mentioned, early on in my career, I did several years of oncology training as a radiation oncologist. So that was really looking at cancer from the other end of the spectrum. So no prevention, it was too late by then, but, treating patients who are often very sick with radiotherapy and other standard cancer therapies. After several years, I actually changed careers and went into general practice because I wanted more variety in my practice. And I did that basically at the same time as my wife, Dr. Deepa, you mentioned. So when we got into general practice, it's a bit different from hospital practice. So patients on a whole are not acutely sick typically, but you are then also struck with a tidal wave of chronic illness. So all the diabetes, hypertension, heart disease, dementia, all of these things that is usually the realm of the GP we were seeing. And we're seeing all these people, we were following all the standard treatment guidelines, and a lot of patients were just not getting better. They were getting put on escalating doses of medications, and there was a lot of polypharmacy, and just everyone was not really getting better. So that was what prompted Deepa and myself to really pursue other therapies, was not out of any particular ideology, just out of necessity to try and find something for these patients. So that's where we stumbled on low carb and ketogenic therapies, and really in the last 6 or 7 years, that's where our practice has really taken off. So that included starting our own low carb clinic and building a team around us to help us manage patients. And so along the way, it wasn't actually at the start, but along the way, this idea of using metabolic therapies for cancer and this notion that cancer is a metabolic disease came up. And with my background in cancer, there was something that came to me quite naturally because I could understand cancer biology relatively well, having had studied some of it in the past. So that is, over the last 2 or 3 years, we've built up a patient population of people with cancer who are either going through active treatment or they've been through treatment, or they've got no other treatment options, who are looking to pursue ketogenic therapies and other metabolic therapies to help with their cancer. So that's really how our practice has evolved over the years.
Yeah, so Dr. Alex, we will come to the metabolic therapies for the cancer, but it would be great if we can start just with a definition, like what cancer cells are and how they are different from the normal cells.
Yeah, sure. So cancer is really a disorder of abnormal cell growth and invasion. And so in the past, there have been several hallmarks of cancer that have been described. So we describe every cancer based on its tissue of origin normally. So we'd say it's a lung cancer, or it's a prostate cancer, it's a breast cancer. And normally we divide down subtypes of cancer based on the particular cell line. So it could be an adenocarcinoma or a squamous cell carcinoma or a melanoma or whatever it might be. But whatever kind of cancer it is, they tend to all follow these same hallmarks. So that includes replicative immortality. In other words, the cancer cell can divide indefinitely. It includes invasion and metastasis, which is one of the more concerning aspects of cancer. So cancer cells can spread to other organs or foreign distant organs. Resisting cell death, sustained proliferative signaling. These are all classical hallmarks of cancer that have been well described for 20 or 30 years. And basically every cancer will follow these exact same patterns. But over time, the hallmarks of cancer have expanded. And one of the newer criteria that is being increasingly acknowledged is this idea of dysregulated or deregulated cellular metabolism, which is really aiming to really quantify that the cancer cell accesses energy in a way that is fundamentally abnormal. And this has really been described well back since the 1940s and 50s by Otto Warburg, who was a German physician who correctly described that cancer cells predominantly ferment for their energy. So whether that's glucose or sometimes lactate, they will ferment fuel for energy, whether there's oxygen there or not. And that's quite different to normal cells. So in our body, outside of red blood cells, most of our cells are typically gaining energy from a process called oxidative phosphorylation. So that involves the mitochondria, and as the name implies, it involves oxygen. So with one molecule of oxygen and glucose, we end up with 36 molecules of ATP out of that. So that's our fundamental energy source. So that's actually quite an efficient way to get energy. So 36 molecules of ATP is pretty good outcome. In anaerobic situations, and most people listening will understand what that is if they've gone for a sprint and there's not enough oxygen getting to the muscles will also ferment either glucose or lactate. So they will use that for energy if they must when there's not enough oxygen around. But to do this, you only get 2 molecules of ATP. So it's not a particularly efficient way to get ATP. It has the advantage of not being oxygen dependent. And it has the advantage of you being a quicker way to get energy. So you actually get the energy much quicker. So for a cell that needs it here and now, it can be quite effective. But unfortunately, that process is not going to be enough to sustain our whole body. And there's a really easy way to tell whether that's going to be the case. And because we can give a rat or an animal cyanide, which basically blocks oxidative phosphorylation, and that rapidly causes death of any organism in essence, because you're turning off oxidative phosphorylation. Now, sorry?
So it's like if we give a people a cyanide, so all of the cells will die and just the cancer cells will still survive.
For a short period of time, yes, but within a dead host, they can't survive very long. But you're correct. So if we give cyanide to too many cell lines in a lab, they're not that fast because they're not oxygen dependent necessarily. As long as they've got available substrate of fermentable material, then they can access their energy. So in that way, cancer cells' fuel source is different from most normal cells. Now, a couple of decades later on, the work of Thomas Seyfried, who I know you've had speak at this conference this weekend, has really identified that not only is abnormal fermentation issue, but the fundamental driver of this abnormal energy behavior is that the mitochondria in the cancer cell is abnormal, is not functioning well. So with oxidative phosphorylation, we do need healthy mitochondria to get the job done, whereas with fermentation, we don't necessarily.
Alex, do you think it could be an adaptive mechanism like inside our body that the cells, they just want to survive and then they follow this inefficient pathway of the metabolism to survive and further to grow as well? It's like some triggers must be there.
Yeah, so that is I think a very good working theory for what's going on. So a healthy cell is not going to start engaging in this behavior out of the blue. So as you say, it's very likely an adaptive stress response where a cell is saying, well, I'd rather do this inefficient method of energy production rather than dying. But over time, that's going to increase potentially stress within the cell. And if you have a cell that's chronically stressed, then that's when things can break down. So the prevailing theory or the prevailing way of thinking about cancer in most modern medical circles is to think of it as a genetic disease, because we can pinpoint that most cancers have many predictable or varied gene mutations, whether it's P53 or KRAS or any other gene mutations. And if we take a biopsy of a cancer, there'll invariably be some abnormal mutations. The problem is they are down the track. They're not the primary driver of the pathology. So they come later as a response to this chronic energy dysfunction. So yes, there are many pathways to metabolic dysfunction that can cause cancer, and we see this in epidemiology. So common carcinogens, so chemical carcinogens like cigarette smoke, asbestos, alcohol, they all are chemical toxins. We can have.
So what does this carcinogens do in our body? Like they are there to they disrupt our mitochondrial health?
Correct, yes. So they are often described in terms of their gene mutation potential. But again, the core driver is metabolic and mitochondrial dysfunction. So there aren't really any carcinogens or any factors that drive up a risk of cancer that are not linked to metabolic or mitochondrial dysfunction. So we've got several viruses that are known to induce cancers in susceptible people. We've got other metabolic factors like hyperglycemia or hyperinsulinemia, which will drive increased risk of cancer. Even things like cortisol might potentially through an indirect route. So all of these factors, they are all going through a root cause, which is the mitochondrial dysfunction. And that is what drives everything.
Yeah, so carcinogens could lead to the mitochondrial dysfunction, but do you think that the underlying health conditions does matter? Because the people who are exposed to the carcinogens, not everybody get cancer.
Correct. Yeah. So I think to a degree, your genetics do play a bit of a role, but again, in what way they play a role is probably down to how metabolically healthy your mitochondria are. So yes, a perfectly healthy mitochondria is not going to get an Epstein-Barr infection or not going to be exposed to one cigarette and suddenly turn into a cancer cell. So it is really death by 1,000 cuts. And if you have a cell that's chronically dysfunctional, then that's when it's more at risk of being tipped over the edge into carcinogenesis.
So let's come to the mitochondrial health. How one can improve their mitochondrial health, and what are the other health conditions or the metabolic disorders, like how they impact our mitochondrial health?
Yeah, so that's quite a complex question in many ways. And unfortunately, as a clinician, we don't really have good ways of measuring what's happening at the mitochondria at a subcellular level. But if we think about what our mitochondria need to be happy, they need good energy balance. So you want appropriate energy partitioning. We want an absence of chronic inflammation, because chronic inflammation is, again, one of those things that can cause dysfunction of metabolic health and mitochondrial dysfunction. And we need appropriate nutrients. So we know there's many cofactors that play a role with mitochondrial function.
But when we talk about the diabetes, in case of the diabetic people, they have really very high blood sugar numbers, but like there is glucose, there is a fuel which is available in their blood, but still the mitochondria is not able to use it. It could be due to the mitochondrial dysfunction. It could be due to the insulin resistance. So, but the cells are really starving. So it means the diabetes is one of the prominent factor that could lead to
Correct. Absolutely. So yeah, that appropriate energy partitioning is a major driver of mitochondrial dysfunction. So absolutely. So we need good insulin signaling to make sure that glucose can enter the mitochondria or into the cell if it needs to. And if it can't enter, as you say, because it's building up in the blood because the insulin signaling is abnormal, then we're going to run into problems. Now, one of the things you sort of see with mitochondrial health is a healthy mitochondria doesn't seem to be as fussed about whether it's using glucose or ketones for fuel, whereas a stressed mitochondria or a dysfunctional mitochondria strongly is going to favor ketones, or it's going to work much better when there are ketones. And you can see this with Alzheimer's, you can see this with diabetes clearly, and other neurological disorders as well, such as epilepsy. So on that front, ketones offer us a very advantageous way to access ATP from the mitochondria if the mitochondria is stressed. or dysfunctional.
Okay, so you mean like using ketones instead of glucose is the more efficient way to get energy?
Correct, yeah. In simple terms, yes. So someone who's got perfectly healthy mitochondria is very likely to be able to access energy from either glucose or ketones. So, you know,
Yeah.
average toddler is
So
going to have no problems accessing energy from either.
it's about whatever fuel is available.
Correct, yeah. So the easiest fuel we can access for a stressed mitochondria is ketones. And that really dovetails well into the cancer discussion, because to use ketones for fuel, we do need those mitochondria working. And we know cancer cells have mitochondria that are not functional. So in many ways, ketones are not a very good fuel for cancer cells, or they're not a fuel source that cancer cells can use appropriately. So the thinking behind the metabolic theory of cancer is, why don't we leverage this to our advantage? So we'll really focus on a fuel source that our body will happily use, but our cancer cells cannot use. And then with whatever small amount of glucose is left in the body, then our normal cells will, again, they'll happily use that, but they're competing against a cancer cell that is very hungry or very addicted to that glucose.
Okay, so before we get into this, it's better that we can start with what are the fuels on which the cancer cells can actually survive and grow?
Yeah, so they are fermenting. The primary fuel source for fermentation in the cancer cell is going to be glucose. So that's far and away the most important one. They do have access to some amino acids they can use for fermentation. The most important one is an amino acid called glutamine, which is the most commonly circulating amino acid in the blood. So that provides an important backdoor for the cancer cell to get access to energy, unfortunately. There is some evidence that certain cancer cells can use arginine, which is another amino acid for fuels. And there is some fermentation with lactate as well, but that's less common and less relevant.
Okay, so glucose, lactate, arginine, and glutamine. So with the help of the metabolic therapies, we will go one by one. Okay, let's start with the glucose. How using the metabolic therapies, you suppress the glucose levels to starve, or maybe so that the cancer cells become more weaker and weaker. So what are the therapies that you use?
So the strongest therapy we can use, and it always is the strongest therapy, is diet. So a ketogenic diet is the best way to limit circulating glucose as much as you can and increase circulating ketone bodies as much as you can. So this has been around for over a century now, and is really the best way of controlling cancer from a sugar perspective. And when we talk about ketogenic diet for cancer, we're really talking about quite a strict therapeutic ketogenic diet, or a traditional ketogenic diet, if you will. So we're talking about usually 3-to-1 ratio of protein to fat. So it's very high fat content, usually 70 to 80% of our calories from fat. Quite a moderate protein intake, so we don't actually want protein intake to be too high, and then generally carbohydrates as low as possible. So for many conditions in our clinic, such as diabetes or obesity or certain other conditions, we tell patients you don't have to chase ketones. The ketones are just part of the process. But for cancer, this is one of those rare situations where we really are chasing ketones. We want them to be as high as possible.
Because you just want to make sure that all the rest of the body is using the ketones.
Correct.
And the cancer cells are the one, because they can't use ketones for the fermentation and they are just relying on the glucose levels. So it's
Correct.
very important to make sure that the body is running, is in nutritional ketosis.
Yes, in therapeutic nutritional ketosis, yes. So, and the way we measure this with patients is with blood glucose and blood ketone measurements.
Okay.
And we use a marker called the GKI, the glucose ketone index, which is very simply your blood glucose divided by your blood ketones. So in that regard, we're really wanting to leverage the sugar as low as possible and get the ketones as high as possible to really spread that gap
out. So what are the numbers you look for then for the GKI, the glucose to ketone index?
So typically GKI under 2 is where we'd like it to be. Basically as low as you can get it. Now, if you think about a GKI of 2, then say your blood sugar is 4, and it's probably not going to fall much less than 4. That means your ketones need to be at least 2. So from simple mathematic perspective, your blood ketones are really going to be the biggest determinant of what your GKI is, because your blood sugar won't change that much. So
how low you get the blood sugar for the cancer patients?
everyone's a little bit different, but typically, you know, between 4 to 4.5 is where most patients will get them.
4 to
Some patients will go
4.5
lower,
mole per deciliter.
millimole, yeah, millimoles per liter.
Okay.
Some patients will go lower, but often the body just will not tolerate it going any lower than that unless it's during a fast, potentially. So the ketones, we'd like to get them as high as possible. So typically above 2 millimoles if we can.
Okay. So the first thing that you target is the glucose. And the other one is, as you mentioned, is the glutamine. Glutamine, no doubt that you're also restricting the protein intake but glutamine is a non-essential in the sense that body in itself can produce, and it's, I think, one of the abundance amino acid which is produced in our body. So do you target both of these fuels at the same time, or you first get the person into the ketosis and then you get to the glutamine?
Yeah, that's a good question. So normally we focus on glucose first because that's the first order priority. And realistically, if a patient can't get the GKI right, then it's probably not that relevant to talk about the glutamine, right? So we talk about the glucose as the front door and the glutamine as the back door. There's no point addressing the back door if the front door is wide open. So we normally do glucose first. Fortunately, with glucose, the diet plays a big role, but unfortunately with glutamine, we don't have many good dietary options because, as you say, it's a non-conditionally essential amino acid, and diet doesn't seem to play a big role there. So we don't have many good dietary levers on the glutamine. And in fact, we don't have a huge amount of drugs we can use either. So with glucose, we do have some drugs we can use, but with glutamine, it's not so easy. So back in the 1950s, there was some research with certain glutamine blocking drugs, and the most common one is something called Eldon, which has been used for cancer in the past. So that's 6-diazo-5-oxo-L-norleucine. That's Eldon. It did show anti-cancer effects in vitro, but the problem is it's highly toxic because unlike glucose, our normal cells, they need access to glutamine.
Yeah.
So significant glutamine blockage is actually quite toxic to the gut and the immune system, a few other things like that. So it's not as easy as glucose. We can't just deprive the body completely of glutamine. And I know there are some studies in some labs using Eldon at a lower dose to see whether maybe it can be useful when combined with a ketogenic diet. But I practice in Australia and we don't have access to any Eldon here, so we have to get creative and look at other potential options for addressing glutamine. But
I think you mentioned that there are some supplements that can also suppress the glutamine or maybe the glutamine uptake in the body, like.
Yeah, so this is probably a good time to dovetail into talking about repurposed drugs, I guess. So if we're pursuing a metabolic therapy for patients with cancer, then there are some other drugs we can use that help things along. In of themselves, they're not going to cure cancer, but they do potentially have advantageous effects. So one of the most common ones we will use is a drug called metformin, which is commonly used for diabetes, and a lot of people will know what that is.
Why you use metformin? To prevent the gluconeogenesis?
So metformin works on both the glucose and the glutamine front. So it appears to inhibit glutamine uptake as well. So it works on that, and it works on reducing circulating glucose and, as you say, inhibiting gluconeogenesis. So metformin is a drug that sort of covers both bases, and it's cheap. It's well tolerated by the vast majority of patients. And if you look at the clinical data, so not even by people thinking about cancer from a metabolic perspective, but if you look at clinical data, patients on metformin with a whole variety of different cancers are more likely to live longer or survive their cancer. So to me, using metformin in this way is a no-brainer. Whether it's brain tumor, lung cancer, breast cancer, it's increasing the odds of survival, and it's also just pushing things in the right direction.
So do you mean that taking even a metformin for a normal person, like who's not a cancer patient, like it's not a good idea, because you said that it suppresses the glutamine uptake as well. Yep. But glutamine is essential for our immune system, for our gut health. So
Correct.
does it mean that mitochondria?
Not a potent glutamine inhibitor. So it's not anywhere near as potent as Eldon, but it's a weak glutamine inhibitor. So
But
on
people are
that front,
consuming metformin for years and years.
yep.
That's why we see, like, people really destroy their gut with metformin. And then they start taking glutamine supplements, Glutamine supplements, they are very common nowadays.
Yeah, and they can be useful for gastro or for repairing gut microbiome and things like that. But during a metabolic therapy for cancer, we'd be a bit nervous about using high doses of glutamine. But yeah, anyway, metformin is one of those drugs that has well-established benefits. They are mild, but they are there for cancer. So
Yeah.
one of those drugs that we find very easy to recommend for patients who are undergoing metabolic therapy for cancer. One of the other drugs or supplements we would use for glutamine inhibition is EGCG, which is a compound found in green tea extract. So it has in vitro activity against glutamine as well. And again, it's going to be a weak glutamine inhibitor, but it has that effect. So because we don't have many options for glutamine inhibition, it's something that's easy to recommend as a fairly cheap, non-toxic supplement that patients can use. The only downside of EGCG is it does potentially interact with certain chemotherapies. So we tell patients to just make sure that their oncologist is happy for them to be on it if they're having chemotherapy.
Okay, but how long do you provide these supplements that suppress the uptake of glutamine? Because are they just suppressing the uptake, or they're also, like, the suppressing the production of glutamine in the body?
So the studies are done, a lot of the studies are done on, in vitro assays. So they're pressing glutamine uptake in cells.
Okay. So, but how long we can give to the cancer patients all these supplements, as glutamine is essential for many in our body?
Yeah. I don't think there's any clear answer on that. So a lot of these metabolic therapies, we don't have a lot of long-term data. So I would say if a patient is undergoing metabolic therapy, typically when they see me, they've either got stage 4 cancer or they've got a glioma, or they're in a situation where there aren't many easy or good standard therapies. So in that instance, we typically say if things are working, so if your progress imaging is looking good, tumor is shrinking, then we're not going to change anything. We're going to keep going. And if things are not looking well, then we might say, look, this treatment strategy is not working. So in that case, you might not need to take it anymore. So at the moment, we're still working within a framework of limited evidence or not enough evidence. We'd always want more evidence, but it's one of those areas that's quite hard to convince people to study. So people like Thomas Seyfried have been trying to get clinical studies approved for some time, and there are some coming, but there's not enough. It's much easier to get an oncology trial off the ground if there's a pharmacotherapy involved or if there's money to be made from a new drug. So unfortunately, that's just how it is.
Okay, that's great. So Alex, in your clinical practice, you are dealing with some cancer patients, as you mentioned, like in collaboration with oncologists. So is it like the both of these treatments go in parallel, like you are giving the metabolic therapies and at the same time maybe taking some radiation therapy or the chemotherapy?
Correct, yeah. So in my practice, I know there are some clinics out there in other countries who are using Eldon and metabolic therapies alone without any standard therapies. But in our clinic, we aim to work alongside the patient's oncologist. So everything, and that's the beauty of metabolic therapy, is everything we do works in parallel, and you could argue in conjunction with standard treatments, whether it's surgery, chemotherapy, radiotherapy, immunotherapy, hormone therapy, all the standard treatments. So absolutely, we work with patients and with their oncologist to be doing everything at the same time. And I think thinking about treatments against cancer in that way is quite advantageous. So this idea that we're going to hit a cancer from every angle possible, if we can, I think that's quite appealing. So there was a time when we were thinking about using, targeted agents or very narrow focused drugs to kill cancers, and that just hasn't worked because all you need is one cancer cell to be resistant to this one therapy, and then all of a sudden you've bred a new resistant cancer cell line. So cancers do need to be attacked from several different angles. And metabolic therapies really work well for that because they're non-toxic, they're generally well tolerated, and they have other health benefits anyway. So So absolutely, we combine treatments with a patient's standard regimen.
So, do you think, I just want to ask, what are your thoughts? Like, for a cancer patient, does the metabolic therapies should be the frontline treatment? And if needed, the conventional treatment can be associated with this?
I think it's very reasonable to offer it as an option for patients. I tell all of my patients that see me who want to talk about metabolic therapy for cancer that this is not an accepted gold standard of treatment yet. And there's not enough evidence there to suggest that a ketogenic diet is necessarily going to cure cancer for lots of people. I think it's an important adjuvant treatment to be added in alongside everything else. So I tell my patients typically that whether it's surgery or chemotherapy or whatever it is, to incorporate that alongside metabolic therapy. Now, again,
Incorporate in the sense like, does it make the chemotherapy or the other therapy more effective?
well, that's the thinking. So there is some evidence that combining it is well tolerated and increases success rates. So I think that's the angle that we would take. So there's no real studies comparing standard of care and metabolic therapy. And to be honest, I don't think we need to do that because they can be done together. They're not mutually exclusive.
Because as I have heard Dr. Thomas say it, because he was saying like if we really start to look the cancer as a metabolic dysfunction, there will be complete change in the treatment. The whole paradigm can change.
Yep, and that's what makes this a very disruptive, almost like disruptive technology. It is quite a big change in how you think about it. So, most of the oncologists that I work with have no idea about what the Warburg effect really is. I didn't learn it at all during my training. So it is a very different way of looking at cancer. But I think the glutamine issue is what gives me a little pause. So if we have a good, elegant way of blocking glutamine in cancer cells, then I think I'd have a lot more confidence. As it stands, it's not quite clear to me that a ketogenic diet alone is going to be enough to cure a cancer once it's established.
It's just
And
like we are putting some kind of stressors with the metabolic therapies on the cancer cells. And
correct.
when they go for the therapies and, the cancer cells are already, they are already weak and they don't have enough energy, to
Yep.
prevent from the radiation therapy. So it's easy to kill them.
Yep, correct. So that's the idea of combining things. So often what we will say to patients is we'll do the press pulse in terms of, we'll do ketogenic diet as the press constantly. And then pulse will be something like chemotherapy. So say a patient has chemotherapy once every 3 weeks, then before their chemotherapy, we may want to add in a fast. And fasting is another tool we can use that's a very potent metabolic treatment. Because if we put a patient on a fast for 48 hours or 72 hours before their treatment, then by the time the chemotherapy is going through the vein, then glucose is as low as it's going to get. Ketones are typically as high as they're going to get. So the cancer cell is maximally stressed from a dietary point of view. And then if you've got a cancer cell that's already weakened, then that chemotherapy may work stronger then. So again, this is very additive, synergistic treatments. They work together in that regard. And the same can be said for other holistic or other alternative treatments, such as hyperbaric oxygen or hypothermia. So these are also hormetic stresses on the body. And if we combine them all together, we may end up with a more successful treatment. And again, there's limited evidence on how all of these things interact and whether they are truly synergistic together. But there are case reports of patients with metastatic cancer going to remission following similar protocols of ketogenic diet, fasting prior to chemotherapy, and using hormetic treatments such as hyperbaric oxygen and hypothermia.
Yeah, but the foundation is a diet. And then later on, we can add on the another therapies, as you mentioned, the hyperbaric oxygen therapy or hypothermia to put the extra stresses on the cancer cells.
Correct. Yeah, correct. I think if you're from a metabolic perspective, if you can't get the diet right, then it's a bit hard to see how all of the other things are going to have a major effect. I think the diet is such a potent metabolic intervention, that it's likely to be the main driver of certainly the glucose side of things.
Okay. Okay, thank you so much, Dr. Alex. So I think now I can invite Shashikant Iyengar and Anup Singh. And I think if
Sure.
we have few questions from the public, we can, because we have time, we still have 10 minutes.
You still have 10 minutes, Jasmeet. You can take up the questions.
Yeah, better. Okay. I don't see it here. Like if we have any on YouTube, let me just see on the YouTube.
In fact, there is also one question which has come out is the correlation of the seed oils with cancer. How far is it true? Because there has been some discussion in the social media on this.
Yeah, I must say I haven't looked too much into that, but seed oils, they cause metabolic dysfunction. So anything that causes metabolic dysfunction should in theory increase your risk of cancer, because it's a mitochondrial stressor to not have access to appropriate energy and to not have healthy energy partitioning. So yes, seed oils are likely to cause a problem, whether it's indirect via the increased risk of diabetes or obesity or insulin resistance, or whether it's another direct means. I'm not quite sure on that. One thing that's probably relevant for a lot of people in India who are using seed oils is when you fry them, there are some volatile compounds that come out of the seed oil under heat. So anyone who's gone to medical school knows the classic lung cancer patient who's a non-smoker is an Asian female. And one of the reasons is they're most likely frying a lot of seed oils. If you look at
Seed oil, isn't that the seed oils, they are in itself inflammatory?
They are in themselves inflammatory, but when you heat them to high heat at their smoke point, they release volatile compounds that you are going to breathe into your lungs. And so it's very likely that one of the ways that you can induce a lung cancer from that in someone who's susceptible is through inhaling these volatile compounds.
Yeah, I would like to share one of the incident. I was invited in the World Cancer Care Organization, which is a global organization. They are dedicated to raise awareness about cancer. I was invited in a camp, and suddenly when I just get to the section where they were just checking the blood sugar levels for the public who are visiting just for the checkup. So I see like the glucometer number, it was showing something around 400, The clinician who was present there, to my surprise, what he said is, he said, nothing wrong with you. What you have to do is just try to avoid a little bit of sugar. And I think you had your breakfast. That's why it's that high. So I got very aggressive. So I thought, I'm here. I don't know why they have invited me. So I just went to the organizers and asked them. So then they asked me to give the public, there was a media person, and he asked me to just give a bite to the media, like they are doing very good work and all other things. So in front of the media only, I said, these people are raising awareness. That's a great thing. But the one thing, first, they should be aware about the facts, because the number 400, that is the critical number and need to be addressed. And all these metabolic disorders and diabetes, which is one of the major factors that can trigger cancer, it lead to the mitochondrial dysfunction. I don't know, the people are really not aware about this, and they are organizing camps, almost 20 camps in a month in the various part of India. That's why such kind of conferences, such kind of sessions need to be done, so that the people should get aware, at least the organizations which are participating, to raise the awareness.
Yeah, it's a huge blind spot with these organizations. When even if you don't understand the mitochondrial aspect of cancer, just epidemiology shows if you're diabetic, your risk of cancer is doubled.
Yeah.
So how many diabetics there would be in India? You just think of how many extra cancers that adds into the health system. It's huge. So I think if we just want to think about not getting cancer, then our priorities are don't ingest carcinogens. So don't smoke, don't drink to excess, don't have exposure to asbestos, and then don't be metabolically unhealthy. So don't have diabetes or insulin resistance. If we can achieve those two things, then the rate of cancer in the community is going to be significantly lower.
Yeah.
There's one more question in the front end in the YouTube that Meat causes cancer. The position of WHO, meat causes colon cancer especially. So they wanted some clarity. You may have discussed this, but again, this is a question that has just come up.
Yeah, sure. So, yeah, it's a well-worn position statement now. It's been around for a while. There's no convincing evidence that red meat causes cancer. That's the simple summary. When you look at the data that's been used to blame red meat, it's consistently low quality and it's consistently based on nutritional epidemiology. And consistently, when we look at higher quality data or when the data is filtered for higher quality or newer studies, there is no relationship at all. Nor should there be. So red meat doesn't really make it into the colon. It's absorbed higher up in the gut. So there's many reasons for why it shouldn't even be biologically plausible. The only caveat there is if we are charring our meat or eating a lot of blackened meat, then that might be a problem. But the studies they use to criticize red meat, or some of the potential mechanisms they use to criticize red meat, chicken is an issue on that front as well. You know, chicken's got heterocyclic amines in it, but it's not associated with increased risk of bowel cancer. Chicken can char and brown just like red meat can too. And again, there's no association with bowel cancer. Even some of the lab studies that are done that the WHO report quotes, the lab researchers, they do these studies and they actually found that chicken caused some abnormalities in the rat guts as well, but they just try and explain it away because it's inconvenient to talk about it. And these rat studies, they are incredibly flawed to begin with, because what they do is they give these rats carcinogenic compounds and they give them a diet that's designed to be, in essence, pro-carcinogenic, and then see what happens. So it's a very artificial situation. And you understand why. You can't have 20,000 rats living a healthy life and then monitor how many cancers they get. It's hard to study carcinogenesis, but the long and short of it is that even if you took that data as real data, the relative risks they're talking about in these studies are minimal. They're very small to begin with. And there's no way of accounting for healthy user bias. So I imagine it's the same in India as in Australia. Red meat is criticised for 50 years, so therefore health-conscious people don't eat it because they think it's not healthy, and therefore health-conscious people tend to be healthier. And however, when you look at a country like, say, or a place like Hong Kong, red meat is not vilified in Hong Kong. It's a sign of wealth. People really prize red meat in Hong Kong. When you look at people in Hong Kong, there's no association with red meat and cancer, because the healthy people in Hong Kong, or the health-conscious people, they still eat red meat.
What about the position of the processed meat? They say that it adds nitrate or nitrite. Will it have any adverse effect? Maybe sausages and all, which is cured meat or something.
Yeah, the effect again is actually quite minimal. So I tend to not favor cured meat for patients, simply because it's not as nutritious. But there's no specific need to avoid cured meat, and our ancestors have eaten it for thousands of years. The nitrate compounds, our body uses those compounds. They're exposed to those compounds whether we like it or not. It's in celery. It's in lots of plant foods as well. So again, very unconvincing when you look at the data on that.
Fine. And I think WHO also, it is they also say that they consider as a probability that it might cause cancer. It is not the surety. I mean, it is not in that sure character. That's how it is. Fine. Anyway, we are coming to end of the session. I'll request to get Anup Singh also inside. Anup, you're there? Fine. Till he comes, Dr. Alex, thank you very much, and you have come again for the session. Please get Anup in. So for the second Metabolic Health Conference, and since this conference was dedicated to the metabolic therapy, specifically in cancer, CKD, neurological, mental health, and we thought, since you have a significant experience in this field, that you should come again and speak to us. And thank you very much. And Jasmeet, as usual, you have hosted very well. And I think we'll get a very good takeaway message from sessions. Thank you. Anup,
Thanks, guys.
Thank you, Dr. Alex, for coming again. This is your second appearance with us, and I'm sure there'll be many more going forward. So
No
thank
worries.
you,
Thank you.
thank you for accepting our invitation and sparing time with us. Thank you.
thank you.
Thanks, guys. Good luck for the rest of the conference.
Thank you. Thank you
Thank
so much,
you.
Dr. Alex.